and take the opportunity to welcome everyone to our meeting. And as I call the meeting to order, Nat, we do have some introductions to be made as well. I think we have Felicia Lowell, our acting director, Health Protection. Health Protection. I think give us a wave. We can see where there she is. Yeah. And so again, we had the opportunity, Jay Beck, to meet Felicia and to welcome her. But now it's an opportunity for the board to get to meet Felicia. So welcome aboard, Felicia, and what a time! This is what you call a baptism in fire, and so welcome aboard.
Thank you.
Members of the board, agenda approval is required at this stage here. Could I have a motion? Judy, thank you. And Reno, all in favor? Opposed, if any, that's carried. Thank you very much. Any announcements of certainly conflict of interest or pecuniary interest on the agenda as presented to you this afternoon? I don't see any, so we'll have that reflected in the minutes in the next meeting. Next, 5.1, Dr. Ahmed, update on COVID-19.
Thanks, Mayor McNamara. Mike or Leanne, if I can get the permission to share my slides. Thank you.
And Wajid, just to be sure, you requested the permission?
Yes.
On the top? Okay, thank you.
Okay, so thank you, everyone. So just want to give you the updates of what's happening in Windsor-Essex. It's no surprise. I think many of you already know. Wanted to put some context into what's the situation overall for the pandemic globally. And as we can see that many of the countries have seen the surge, second wave, much worse than the first wave. And some of the countries that have taken some steps to control, and the result of some of those measures that are currently put in place with respect to adding more restrictions versus not doing enough. And some of the examples that we can see here in many different countries, starting all the way from France, that has seen a huge surge, but back in end of October, early November, they went into complete lockdown, and then their rates are now gone down to pretty much similar to what Canada is seeing right now. United States, as we know, we haven't seen more strict restrictions, and it continues to go up and up with the case rates that they're seeing right now. Some people use example for Sweden in terms of how they have managed their pandemic, and they didn't do much with the first wave, and they advocated for the herd immunity model, which basically is not to do anything, and eventually everyone will get sick and everyone will be fine. But now they're seeing that their strategy has completely failed, and now they're calling in for more restrictions, but their situation is keep going worse. Germany has done a great job in terms of limiting their first wave with strong restrictions. With the second wave, they didn't go all the way with the strong restrictions, and they had a combination of some loosening of the restrictions, and they continue to see some improvement, but overall they continue to see more cases. And Canada is pretty much on the on a steady pathway, but our second wave is still worse than the first one. This is what the cumulative case counts look like around the world, and again, just looking at different countries based on what they have done in putting in some of these restrictions and measures in place. Looking at the number of deaths that's happening around the globe, obviously, no surprise again here, U.S. continues to lead with the daily number of confirmed deaths among people, followed by Sweden. And again, they're seeing a large number of cases or a large number of deaths in their population, and followed by all the other countries. So, Mark is emailing me that the image is cropped. Is there, Mark, can you just respond if you're fixing it, and maybe I can just stop for a bit?
Yeah, sorry. Radek is coming into your office right now. You have to share the application instead of the window. He's going to help. So
Okay.
just 1 second.
Where's your mouse?
Good job, Brad.
From current slide? Yeah. Okay.
Yeah, just keep it on the other window where you don't go full presentation mode for now, because that's at least showing the whole picture. Yeah.
Okay.
Yeah.
Is this better?
Yeah,
Brian?
I mean, you can see the whole picture anyway. Watch. Yeah.
Okay. Okay. So apologies for the technical glitch. So moving on in terms of the daily number of confirmed deaths around the globe, compared to all of these countries that we've mentioned, Canada's death rate is still much better, showing overall as a country we have done a good response, but still the cases continues to rise locally as well as in the province and in across Canada. Looking at just focusing on Ontario, this is what the picture looks like. The case rates continue to climb, and even today, we have broken our record by reporting more than 2,400 cases in the province. And focusing just on in Windsor-Essex, the situation still is pretty. Is also getting worse with our daily case rates continuing to go in an upward direction. This is what it looks like just from between September and present. We did very well in the month of September and pretty much for the most part of October, but things started to get really worse starting in November and all the way in December at this time. This graph shows you how quickly the cases are accumulating, and the way to interpret this graph is to look at the steepness of the curve. And as we can see in the last month, the curve is really steep, showing how quickly we are crossing those thresholds in a short period of time. And just yesterday, we reported that the last 1,000 cases came in just 10 days. So that's a concern. And with even today reporting 191 cases, we may expect to see our case doubling rates happening very quickly than before. Overall, when we are looking about the Windsor-Essex rate by reported week, this is what it looks like, and it continues to increase every week. And as of last week, we are at 165.3 per 100,000 population case that we are reporting. And just as a comparison, we went into a red zone when our case rates moved from when our case rate was higher than 40 per 100,000 population. So basically, we are more than 4 times the threshold that was set for the red zone. And this week, we were put in gray lockdown mode. From a person positivity perspective, that number of tests that are being conducted and how many test results are coming back, our person positivity is increasing too. We are currently standing at 5% of person positivity with all the tests that are being conducted in Windsor-Essex. Looking further into the municipalities from November 1st to present, and this is what the picture looks like, with Leamington is still, based on their population, leads the way with 732 cases per 100,000 population by municipality, followed by Windsor, and then Tecumseh as at 503 cases per 100,000 population. The distribution of cases just in the last 30 days, it continues to be Windsor with 71% of cases. And while the majority of the municipality are showing some activity with the variable number of proportion of cases between 2 to 5% around the municipalities. The age and sex distribution of overall cases in Windsor and Essex, we have seen some shift more recently between the ages of 0 to 20, and also from 20 to 29 age group. A lot of those cases were linked with school cases, and even in the last 2 weeks, we have seen a significant number of cases in the school population. And as many of you are aware, which prompted us in switching to online model for our schools in the region. Are looking at further breaking down by the exposure history. And as you can see, many of the cases are still under investigation in the gray bar. And while the majority of the cases still is coming from the outbreak or the household contact perspective, but we are still seeing a significant number of community transmission. And when we're looking at that, even when we're calling about 25% community transmission, but with the 200 cases, 25% community transmission means 50 cases that are being acquired from the community, which is which definitely identifies the underlying fact that there are more widespread community transmission happening. And the number of cases that we are seeing is a reflection of all of that, because the cases are coming from every direction: close contact, household contact, outbreak, travel, and also including community. The number of outbreaks that we are dealing with right now, I believe Teresa reported, today we reported 27 active outbreaks, and that number is increasing, including one of the outbreak that we have declared at our hospital, Windsor Regional Hospital, and also Hotel Du Grace Healthcare is also in an outbreak right now, on top of many other facilities, including long-term care home and retirement home. Overall, from a case fatality perspective, we are below the provincial average, but still showing a significant number of deaths that are happening. And again, case fatality is a lagging indicator for many of the cases that we are seeing right now. So whatever we are seeing, it may have an impact on the case fatality rate at least 2 to 3 weeks from now, and which would be further bad news for our community in terms of losing our lives. The case doubling time, we did very well between August and all the way up to early part of November. And then now our case doubling rate is down to 14 days. So technically, whatever case we have, within 14 days, we can double our case if we continue with that rate. So median R effective rate is the reproduction number that we see. That means one case will result in how many additional cases. It currently stands at 1.36%, 1.36, which means that every case is capable of producing 1.36 the cases in the community, which is significantly high, indicating that the ongoing transmission and ongoing increase in transmission. So the cases will continue to increase unless this R effective rate goes down to under 1. If it's below 1, that means the number of new cases resulting from current infections is going down. But so far, at least for a month, we haven't seen that. We have always seen that it's going up. So that is a significant concern for our community. So in summary, our case rates is increasing at a rapid rate, much higher than the provincial rates. And right now we are standing just behind Peel in terms of the case rate that we are seeing. And we have reported significant number of cases more recently with all our cases in the region, jumping very quickly, racing quickly to 5,000 cases, and still reporting more cases. The acquisition source is distributed everywhere, which is indicating widespread community transmission. Our hospitalization has definitely increased with the number of active outbreaks. It's posing a significant pressure in our hospital system at this time. Our day-over-day doubling time has decreased significantly. And right now we are doing much worse than the province as well as Canada. And our effective rate is indicating a significant increase in transmission in Windsor-Essex, and we will continue to see more cases in Windsor-Essex as we move forward. So I'll stop here for any questions or comment from the board. Thank you.
Thank you very much, Wajid. I think it's pretty much self-explanatory. We're just going in the wrong direction, period. Judy?
I think you're muted, Judy, or am I the only one that can't hear?
No, she's muted.
Are you there, Judy?
It's right at the top of the screen. Left hand, should be right in the left-hand side. Your little icon there, the microphone.
If that doesn't work, Judy, that little settings icon on the top right will allow you to select your audio device.
Oh, while Judy's trying to figure it out, then I'll move on. Joe, McKetty, and then Reno. Go ahead, Joe.
She muted too?
Frozen or okay, Reno.
Gonna be a quick meeting.
Can you hear me?
Yep, we got you.
Perfect.
Go ahead, I'll go back to you, Joe, after.
Just looking ahead, and obviously the numbers are trending in a negative way. Do we have? Do we see foreseeable change in the plan other than the gray lockdown? If there's more stringent measures or other changes that would follow if those numbers continue in a negative trajectory or positive, I guess, as the numbers get bigger, would we see other actions taken? And I know, for example, the action to close the schools was a local decision versus the gray shutdown rules. Do we foresee specific, whether it's things, action at long-term care, potentially other types of shutdowns? Do you foresee anything of that nature going forward if these numbers continue?
Through you, Mr. Chair, no, definitely that's something we are considering at this time. A group of MOHs who are in the lockdown zone right now, and also in the areas that are in red. So we are having this conversation to have some kind of a plan put forward, either collectively as the medical officers of health in this region, and to look for maybe a little bit more consistency across the board, because we want to make sure that the plan that we are putting forward, it makes sense from a local perspective, but also ensuring that it is applied consistently across the province, rather than just doing some piecemeal efforts. Some of this conversation is ongoing. We are definitely looking at all the options at this time, and I'm hoping that some of these conversations will result in further consideration and further restrictions, either locally or across the board.
Have you experienced issues with travel, even just in between regions, and or border issues as well? Just because we're in gray, but any region up the 401 may not be, and the lack of sort of rules around that governing people's movement around the province.
We do get some data for our internal planning purposes from a company called Blue Dot that provides us mobility data, tracking the cell phone signals that they can catch, like in terms of people moving from one region to another. It does show that even in GTA, despite the lockdown, the movement stayed pretty much the same. So that means people are still going out. So we do have that indication in the GTA area, but also we've been in discussion with that company to provide us maybe with some data that can give us a little bit more understanding of our border issue, to see what's that pattern look like. So we are trying to get that data to have a better understanding there, but it's tough to say who is going where, but I anticipate that traveling is still happening, and there's not much some people have lots of time, and they don't mind going to a distance to do whatever they want to do, and some of us do feel that the second wave, the impact of second wave is probably because of people still doing what they do, and if they can't do it locally, they're going outside.
Thank you.
Joe,
Yeah, can you hear me now, Gary?
Yep, loud and clear, Joe.
Okay, thank you. Just a question, Dr. Ahmed. We always hear in the media with regards to the number of cases that are under investigation. And just could we clarify or make it simplified? What does that actually mean? Is it contact tracing, that out of that number, there could be or could not be more COVID cases that are confirmed? Because a lot of people are thinking that as potential confirmed or not. So the number under investigation, if you can maybe explain that.
So I will try to explain that, and maybe, I don't know if Teresa would want to chime in after. So anything that we are reporting, these are all confirmed cases. Even when we are saying these are under investigation, it doesn't mean that they don't have COVID. They have COVID. It only means that we don't know their exposure source. Every morning, Teresa gave a breakdown of how many of them are close contacts, how many of them are part of an outbreak, and how many of them are community transmission, and how many of them are under investigation. So all of those, if you add them all up, these are all confirmed cases, so there shouldn't be any doubt about that. The challenge is by the time when the case is reported to us, and then when we are reporting it back to the community, we may or may not know all the exposure sources. So we don't know those under investigation. We don't know if they're close contact. We don't know if they're part of an outbreak, or we don't know if they're part of a community transmission. And it takes some time for our team to interview them. And that interview is done by our trained nurses who identify the exposure source based on the behavior, based on the activities in the last 14 days. And it's really a time-consuming process to get that information. Sometimes it's very quick, we can get that. So those are the under investigation category. I don't know, Teresa, if you want to add anything. She's saying no.
Yeah, so basically under investigation, those numbers are confirmed cases as well.
Yeah,
okay, thank you.
All right, Judy, let's give you a shot here again. You can't hear us?
So Judy wrote her question in the text box. If Gary, if you want me to read that question.
Yep.
So of the community transmission, some people are having to go out to work. Do we have a sense of people who are working but wearing masks, staying socially distanced, are community transmission, or is the people who are not following the mask, et cetera, guidelines? It's a good question. So community transmission is something when we are saying, so most of the cases, the way we do the transmission or understand the transmission, you have to have a person who is sick to pass it on to someone else. When we can establish that link or connection that, yes, you met with someone who is now positive or a suspect case, then we can link them as a close contact. But in some situation, despite our interview, we cannot link it whether you met with a positive person or not. All your investigation is telling that you didn't come in contact who was either sick or who was a confirmed case of COVID. So in those situations, we report that as community transmission. So it can be either or. It doesn't necessarily is linked with wearing the mask or not. Thank you.
Ed? And Larry after. Yeah.
Gary, can you hear me?
Yes, yes, we can.
Okay, great. Looking at the number of cases going up, do we have anything to worry about that whether we have enough bed at the hospital to take care of this increasing number? That's my concern. Are we going to modify it? Are we going to continue working with the hospital? Are we working with them? That's the point.
So through you, Mr. Chair, we are working with our hospital partners when it comes to the some of these issues. They also have another table completely through Ontario Health that's responsible for this type of planning. We know that they are really stretched with the number of COVID positive cases, and they are scaling back some of the elective procedures just for that reason. And a lot of that planning is happening within the hospital sector through Ontario Health. We're not involved in those planning, but we are aware of their pressures and their challenges.
Okay, thank you, Dr. Ahmed.
Okay, Larry. You still there? Yep. Looks like Mayor Snively's she's frozen. We'll go back to Mayor Snively after. Reno, I think you had your hand up.
Thanks. I'm just wondering where we are capacity-wise, staffing. Obviously I feel like we surpassed our capacity months and months ago, but where are we with respect to being able to handle what's happening now? Do we need more bodies? Do we need more people calling for contact tracing? Like where are the gaps and where are we potentially falling behind because of the sheer volume?
So I'll pass this question to Teresa. And I don't know, Teresa, if you'd like to answer.
Yes, so we actually have in Committee of the Whole, I have a proposal I'd like to present, but I can tell you that the pressures of case management are keeping our staff very busy, but also stretching us very thin. So the contact tracing piece seems to be well supported. It's the case interviews, and that includes the nurses that currently we have 51 staff that primarily nurses that are doing that direct work of case management, including the initial calls, informing them they're positive, discussing signs and symptoms, reviewing their infectious period, educating them on the disease, medical follow-up, getting the lists of their contacts, determining their infectious period and their isolation requirements. So all of that is where we're behind. The contact tracing is the next piece, and that is being managed by a group of ministry workers that have been seconded to help us. And there is also another referral system to Public Health Ontario. So the contact tracing piece is being managed. It's the case interviews. So as you are aware, we're getting results of hundreds of cases every day. So with 51 nurses, that's not enough. And in Committee of the Whole, I want to discuss a possible augment to that.
And just thank you. And following up, is there any ability to, I know the mayor publicly stated that if there was a need to deploy city staff to do some of that, is there any opportunity or is it too difficult to train someone not a nurse or a healthcare professional to actually come in and help with some of those initial interviews?
So the initial interviews are very, not very, but they are complex. It requires the ministry database system, the documentation, a whole management workflow that is initiated through the lab results coming in through this system and then accessing those results and doing those detailed interviews and the proper documentation and referrals on for contact tracing. It is primarily done by medical people or professionals. We also have pulled our registered dental staff to help with that and other health promotion specialists. So that has to be a pool of professional people. The work that we discussed this morning with the the recent offer through the city of potentially other people. We did have a meeting early this morning to talk about other pressures and how we can get more people internally to do case follow-up. And so we do want to look at possibly taking up the city on an offer and helping us with the call center. So behind the scenes, we have internal people, mainly dental staff, helping manage the many, many calls we receive. And so there are scripts for that, and possibly that's one avenue to help us. And also possibly some support with our communication, if that's something the city could help with. So I want to be able to articulate it all very well. This was just a recent offer, and we really do feel the case management part, though, needs to be handled through our like a capable, competent process with professionals that are familiar with the interviewing and the complexities of COVID.
Thank you.
Teresa, just on that point, I know the county as well. Our librarians that are idled were offered a couple of weeks ago in that regards. But from what I gather, it seems to be like a two-stage process. Obviously getting them initially, okay, now these individuals now have tested positive, and then okay, pass it on, and then the other piece, basically the tracing piece, and having that conversation with them. Certainly, I guess my question would be, and I think you partially answered that, would be if we could find a way to do the, I'd want to say mundane, but those that didn't necessarily don't require a nurse, but it relieves the amount of time that the nurses could be doing on the other side. Because from what I gather, and everything that you mentioned in terms of what they have to ask and so forth, on average, if the nurse interviews one client, how much time would that take? Would it take 10 minutes, 15? And where I'm getting at that, especially when you're getting 190 cases a day, and if it takes 10 minutes each, well, you can figure out it doesn't take long that you chew up the 51 nurses and to try to get a handle on the whole issue. So I guess my question would be: does it make sense to kind of get the professionals or the nurses to be just dedicated on that specific duty, and others could do the the non-professional piece, and then how much time does a nurse spend on average on a client?
So the case interviews that are conducted earlier on in the pandemic, when there was a lockdown and people did not have any contacts, they were the average amount of time would be an hour. The initial case interview is very critical because you're reviewing all of their time where they've been, in the presence of others while they were symptomatic. So when you hear about people that are symptomatic, they can actually spread the infection 2 days prior to the development of symptoms. So you have to go back to say, where have you been? So now you can imagine people are working, they're going to school, they're going to other outings. So what's happened is that there are more and more contacts, more and more places they visited. And so that's increasing the work of all of our staff, because then that all funnels into our environmental health department to follow up on the workplaces, the other areas of the potential exposures. So the interviews right now are taking about 2 hours, because the nurse in that interview has to get every high-risk contact information on that person. So it's usually your household members and then any of the people you've been exposed to until you began isolating. So with a little bit of delay in getting your test result, and say and we've had this where people have gotten the test and then gone out and about. and so they should be isolating. So it really takes quite a while. So your estimation of 10 minutes is certainly not the case. It is taking.
I didn't. I'm just saying, how much time.
Yeah.
Don't get me wrong. I wasn't suggesting it takes 10 minutes. But my point, what I'm trying to bring across, Teresa, is the fact that when you first hear, there's 51 nurses doing the work, and people say, well, that should be okay. But when you've got, 150, close to 200, and you chew up those 51 nurses easily, and that's where people are don't understand the complexity and the amount of time in order to do a proper investigation in terms of contact tracing. And so that's the area that I think, obviously we need those nurses solidly into that area, and others, if they can come in to kind of, direct traffic and take those calls. I think that's important, and certainly would like to have further discussion on that and any ideas in terms of getting the resources that you need, because I agree with Reno, and in terms, the fear for us is that you're running yourselves in the ground, and with the case numbers going sky high, we want to make sure that whatever resources that are there, that you can max out to the benefit of finding out where the contacts are coming from, in those issues. So that's where I was coming from, in that, and certainly in that regards. Mayor Snively, I know you were frozen out. We couldn't hear you. Can you hear us now?
Oh. No, what's happening?
He's too far out in the county, Gary.
Okay. Thanks,
Have you got me?
Yeah, I got you now.
Okay, I'm having a lot of trouble here, and IT's already been in here and looked at this. It's a mess. So I keep going in and out. I have a couple of questions to Dr. Ahmad.
He's not here.
Okay. Well, I think we've lost him again. Deborah, did you?
I don't want to cut him off.
No. Mayor Snively, you still there? Okay, stay tuned. We'll get back to him, if they can get that organized. Deborah?
I was just going to say that I have 5 recently retired colleagues, registered nurses, who have been asked to help, not through Windsor-Essex, I believe someone out of the ministry, to help with the calls, but they actually were told you have to commit full time because of the training and the length of time it takes to do each interview. For someone to give half a day is not worth the time to train them. So it is a very time intensive work.
Understood.
That's all. Yeah.
Thanks. Thank you for that. Anyone else?
Yeah, Chair, it's Gary Kashak. I'm calling in on the phone here today. I had computer troubles as well.
Yeah, no, go ahead. Go ahead, Councillor.
Thank you, Chair. Question for Dr. Ahmed. Doctor, you recently mentioned in the media there about further border restrictions, and I was just wondering if you had made any headway on that. I know we can't do anything with our essential workers, but I believe there are quite a few people that are crossing the border being deemed as essential that really aren't. So can you give us an update on that situation, please, Doctor?
I believe Dr. Ahmed had to attend a ministry meeting at 4:30 for a few minutes. So I think he's left a message that he has stepped out for for this important meeting.
Sure, Teresa, would you have any update by any chance, or?
Oh, sorry, I don't on the border at all. I'm sorry.
Maybe with the absence of Dr. Ahmed, who's dealing with the ministry right now, maybe we can just suspend this portion here on the report and questions. We can always come back. So, Councillor, if you want to just hang on, and then as soon as we get him back, and we'll continue on with some of the business here and keep things moving, and we'll get back to your question to Dr. Ahmed.
Sure, thank you.
Okay, we'll certainly move on to the now required approval of the minutes of the regular board meeting of November 19th. We've got to have a motion on those minutes. Both Councillor Bordelin, Councillor Constante, any errors or omission on those minutes as presented? I'm hearing none. All in favor? Opposed, if any? The minutes carried. Any business arising from those minutes? I don't see it. So then we'll move on to the consent agenda. We have 5 items to deal with. If I could have a motion to receive the consent agenda, John and Deborah. And before I call the question, is there anything that maybe administration would want to highlight on their reports? Okay, all in favor? Opposed, if any? That is carried. The recommendation, there's one report. We'll go to reports 8.8-2-1. That's Bill 216, an act to amend the Education Act. That's a food literacy. Maybe I'll ask Nicole, if you want to certainly bring that report forward, and maybe you can give us some highlights of the report.
Sure. So the report on page 17, we're requesting a resolution from the board in support of Bill 216, the Food Literacy for Schools Act. Basically, if implemented, it would require food skills literacy to be embedded throughout the curriculum. Something that was in place quite a long time ago and no longer is there. We know that food skills is linked to healthy eating and it being part of the children's curriculum throughout from grade 1 all the way up to grade 12 is certainly something we've advocated for a long time. We do our best with our own programs and efforts, but we're certainly not in every school and every classroom all the time. So this would go a long way to improving our efforts in improving healthy eating and helping certainly to curb chronic disease in the future. So if you have any questions, I'm happy to answer them. I think it's fairly well described and hopefully you all agree to support.
Okay, thank you very much, Nicole, for that. Members of the board, what is your pleasure? I think this is a report that should be endorsed by the health unit. Reno, move, and supported by Joe Bicchetti. Any further questions or comments? I'm hearing none. All in favor? Opposed, if any? That carries.
Thank you.
All right, we'll move on to new business. We have a long-term service award. And I'm going to pass this on to Teresa. Unfortunately, this is always the time of the year where we kind of gather and help celebrate the milestones. But we have to be a little bit creative this year in particular. But certainly, we will not underscore the importance of recognizing long service awards. So Teresa, with that.
So thank you. So last year we did bring our staff to the board meeting and acknowledge those that had more 20 years of service and more. So this year I will tell you their names and where they're actually working. They're not physically here, obviously, but most of our staff are working remotely from home. And then we'll post it on the intranet. And I think that'll mean a lot to them that it did get brought forward to our board. So we started with the 20-year awards, and I'll just list the names and where they're working right now. So Kim Hillier is a family home visitor, has been with the health unit for 20 years and is in the Healthy Families program. Elaine Bennett is a public health inspector in environmental health. Yelena Reeves, public health inspector in environmental health. Valerie Del Rue is a nurse in Healthy Schools, has worked in COVID as well. Michelle Campignoni is a nurse in CDIP. Jody Wade is in Human Resources under Dan Sibley. Carmen Gascon is our finance payroll person and under Lori. And Deb Sylvester is a manager in Healthy Families, but is currently managing the COVID work in the schools, and she reports to Nicole. So those are our 20-year recipients. We have one person who's worked here 25 years, Lulu Hermano. She's a dental hygienist, and she's in our oral health department, and at one time reported to me, and she's just a very dedicated, committed employee, as they all are, but Lulu's just a real joy as well. So she's been here for quite a while. 30 years is Martha Burrows, a nurse in our Healthy Families department, and has been seconded to COVID pretty well from the beginning, and is one of the case investigators we do talk about. Jeanette Forsyth is an executive assistant to Lori in corporate services. 35 years is, there are two recipients, Kelly Hickson, who is in facilities, and also Sandra Woltz is a dental assistant in oral health. And we also have one person who's been here for 40 years, and her name is Serena Kwasnicki, and she's a dental assistant in oral health. And so that's it for now. They will all receive a card and a gift card, a gift certificate based on their years of service, and we'll post this to the intranet and congratulate them. So thank you.
We'll make sure that you extend our best wishes as members of the board on their long service to the health unit, but to our community. So on behalf of all of us, we want to extend our heartfelt congratulations.
Thank you.
All right, we'll move on to 9.2 records management. I believe, Laura, you're going to bring this forward.
Hi, yes. So this is actually something that Nicole and I have both been working together with. Nicole was the driving force behind it. So there is a software, an electronic medical healthcare management tool, or an EMR, referred to as EMHware. It's a tool that helps promote the efficient and effective communication interactions with clients. The system itself has several tools that help with those interactions with clients. And if we were to adopt such tool, it could be utilized by several departments within the organization. Oral health, for example, our Healthy Families program, and in the infectious disease program as well. Some of the tools that this electronic medical record software has are platforms that allow for virtual interactions with clients, which, since the inception of COVID, obviously that has been very crucial, and we see it as something that will continue on well into the post-COVID time. And as well, there's the opportunity there's a referral process embedded in the system as well that would allow secure referral with partner organizations. Currently, this tool is being utilized by a number of organizations in Windsor and Essex County. Children's First is one such organization that we've actually been communicating quite frequently in regards to understand their experiences with the software. So we bring this before the board today because we're looking to do, and in accordance with our procurement policy, as our procurement policy requires anything that's a non-competitive procurement in excess of $2,499 to be brought before to the board for discussion and for approval. This procurement of this electronic medical record software would result in an increase in operating costs of $15,000 per year And that's assuming that we would have a licensing model of 100 users at $150, and it'd be $150 per user per year. In addition, the upfront implementation costs associated with software are roughly $10,000. And that includes costs associated with doing virtual training by the organization and any report building and such that we require in order to make the platform usable for our organization. So we bring this before you today and request a motion to approve us being able to move forward with this procurement. So again, the figures are $15,000 per year, tentatively on the licensing, assuming that we stick with the 100 user model in the first year, and the one-time implementation costs of $10,000.
All right, thank you, Lori. It sounds like a great tool to free up a lot of the staff time, and I think it's certainly I think a great investment that we can make. All right, members of the board, pleasure. Excuse me. Moved by Reno, supported by Joe. Any questions or comments? All in favor? Carrie.
Thank you.
I'm going to get John to take over. I got to get some water. I'll be right back. John.
Yeah, I got you, Chair. So we're moving right along here. We are at the recap. Are we at the recap for the communications?
I believe it's item 10, John, the letters.
Oh, yeah, sorry. You're right. Sorry. Let's look at our, thank you, Teresa. Let's look at our resolutions and letters. We have our first one, which is, or we can do these all together unless they need to be commented on. These are all for information for you. I hope everyone's had a chance to look at these, 10.1, 2, and 3. 3 letters. Is there any comments from administration on these letters? Nothing? Hearing nothing? So we'll look for a resolution to receive these. And that's moved by Ed and supported by Judy to receive these 3 letters. Thank you. Okay, any questions on that motion at all? Okay, all in favor? And that carries. All right, so Gary, we're all done the other board resolutions. And I believe I'm going to turn it back over to you for Committee of the Whole.
All right, thank you very much, John. Okay, so we will, I'll be requesting well, first of all, is Dr. Ahmed back with us? Nope, not yet, okay. And the only thing here is that obviously those who are on the phone and not on team right now will have to vacate the phone and that's part of our bylaws indicate that no one can be on the Committee of the Whole via phone, just in person video. So with that, I need a motion to move into Committee of the Whole. Reno and John, all in favor? Opposed, if any of that is carried. And if you go to